My doctor told me that the best way to lose weight is to go on a diet, or to change your diet, and to do more exercise, less of this to this, and to change the way you eat, to change your lifestyle, and to do more exercise, because it's calories, versus calories in versus calories expended. It's not working. It's just not working. I've tried it, and I keep careful records. It's not working.
Many times by the time patients get to my office, they will tell me, I have tried this diet, I've tried that diet, I've tried many things, I've gone to commercial plans, and I can't seem to lose weight. What am I doing wrong? I think that's a great opportunity for me to acknowledge to them, you're not alone. This is a more complex problem than just one set diet or one set activity plan, and really hone in that this is a complex chronic disease, and it takes multiple approaches. Also that it takes individualization, right? And so there's not one cause for your weight to be what it is today, and we're not going to solve it by one set solution. What are your thoughts?
Patients come to me all the time and say, it's not working. I'm really watching what I'm eating. I'm maybe exercising or maybe doing a little of both or one or the other, but the plan's not working. What do I do? And they're very frustrated. The first thing I usually do is let's make sure it's not working, because their definition of it's not working might not be necessarily my definition of it's not working. So a lot of times, sometimes, I lost 10 pounds or 20 pounds and now I'm not losing any more. It's not working. That's a little bit different conversation, because we know that it has worked. It produced a weight loss. You don't lose weight forever. When it comes to lifestyle changes like changing your nutrition, whatever you do, whatever diet you choose to reduce your calories and moving more, it's going to have a certain impact, a certain effect. You're going to lose a certain amount of weight, and then it's not going to decrease your weight anymore. Similar to like a blood pressure medicine. You would take that blood pressure medicine, you would lose, your blood pressure would go down, but it wouldn't go down forever. And it would, it has an effect, it has an impact. Lifestyle change, same thing. A diet, physical activity, you'll lose some weight, and then you just maintaining. And it's working. It's just that expectation that they can keep going. So I always like to talk about what does that look like first. Then second, let's say they are making some changes, but the scale hasn't moved. And so in that sense, they haven't lost any weight. And that's really what they're talking about. I then like to kind of bring up the fact that for weight loss, nutrition has to be dialed in. For most people, there has to be some plan, and multiple diets. There's not just one diet, but some nutritional plan, some diet that restricts calories so that you can burn body fat, put you in that negative energy balance that we talk about. And for a lot of people, they think, well, I'm walking a little bit more. Shouldn't the scale go down? Not necessarily. Really, the amount that you would have to walk to produce a weight loss is a larger amount. So we kind of talk about that nutrition is really important for the weight loss. What are you doing to reduce your calories? Lots of different strategies to do that. Not one way, but what are you doing to do that? Might switch strategies at that point if they've been doing it, it's not working. And then also talk about that physical activity, super important for lots of reasons, especially for keeping it off. So I usually start that conversation kind of that way and see where we go, see where we get.
I like to bring up that physical activity piece, because people say, I've been going to the gym every day and I haven't lost any weight. Right? And so I think it's important to say it's a combination, and really more on the nutrition piece in the weight loss phase, and then really more on the physical activity on the weight maintenance phase. For instance, you can exercise or even, run 6 miles in an hour, but you could eat a donut in 3 minutes, right? And so is that really going to pan out? So it has to be a combination. I also would say that we emphasize a lot of changing our lifestyle, and for sure it is the foundation of our treatment plan, but it's only the foundation. On average, lifestyle in all of our trials are around 3% weight loss. And that might not be the goal that our patients or the goal that we need for their health condition.
Absolutely. I think a part of this is also understanding what their expectations are and adjusting them if there are unrealistic expectations. So some of that is just bringing in the understanding that there's got to be a nutrition plan in addition to exercise, but also setting realistic expectations.
Right, that you're only going to get so much weight loss probably with that lifestyle intervention. And it really been successful. They just expected a 20% weight loss with it. And that's really not, for most people, what they're going to get with lifestyle intervention, behavioral change.
And once you've reduced your weight to a certain percent, then you've got to sort of have a new plan and a new strategy, because the same thing isn't going to continue to work as quickly and maybe as effectively at lower weights.
Yeah, and I think that's the thing that they think it's not working. Well, it worked. So it's a different mindset shift. I then think there are patients who really are doing some behavioral change, not having very much weight loss, not successful. So there are things we can add in. What other things can we consider when someone is, making the effort to watch what they eat and moving more, and the scale really hasn't, moved enough for them to have a benefit?
I think one of the things that is not addressed enough is not just what the patient can do, but the things that other providers have done to them, which is the medications. So one of the first things I look at when patients come in is, are they on any weight gaining medications? So this is a time that, hey, while removing it may not cause a lot of weight loss, it for sure is not helping us. So is this an opportunity to make some changes? So in addition to lifestyle, I'm looking at other causes for their weight gain. Changes in lifestyle is definitely the base of our treatment, but it's not the whole thing. If we look at one of our most robust trials, which was the Look Ahead trial, the amount of weight loss that most patients experienced was on the low side, 5 to 7%. And that was not in the majority of patients. Would we do other treatment approaches that only ended up in 10% of people maintaining that 7% weight loss? Not usually, right? Would we prescribe a statin that only worked on 10% of people? So we need to look at a layered approach. That's what I talk to my patients about. Lifestyle is the cornerstone, but now we need to look at other things that are happening, because as you're losing weight, your body is starting to pull you back, whether it's by lowering your metabolic rate or by making you more hungry. So that's when I bring about what's working in your plan and what's not.
I think an obvious tool that we are getting more and more options are weight loss medications, pharmacotherapy for body weight regulation, for weight loss, and for long-term maintenance, and adding that on when it is appropriate. When do you think about maybe adding a medication or starting a medication in one of your patients?
It really depends on the patient, because there are some patients that they tell me, I've been doing the eating plan and the physical activity and I'm not making any progress, and we're looking at their complications of their weight. I'm going to be more likely to start it even from the first visit. So it's not a number of visits. I really look at what their goals are and what their health goals are, and adding that on, especially with the, we're at 237 obesity-associated conditions. And so I know that I can treat, the underlying cause of those complications with more weight loss. I think we're really, if we think back about even blood pressure medicines or even with mental health medications, we're at that stage with obesity where we are getting really effective, safe, long-term treatment tools on the pharmacotherapy side.
Yeah, and multiple tools. So if one medication doesn't work, you can actually try a different medication, or if you have a side effect with one, you can try another. And that's really where we need to be, where we have multiple options, just like we have multiple options to treat high blood pressure. If one type of high blood pressure pill doesn't work, we have others, and we can combine them and things like that. So I think we're starting finally to move in that direction and have that, option. One thing that healthcare providers always ask me is, should I make my patient try lifestyle first and then add on a medication, or should I start with a medication right away? Let's say their body mass index is 30, so they meet criteria where the risk and the benefit of potentially a medication, we believe that's the body mass index where we should think about it. We can consider it from that kind of risk-benefit standpoint. Do they need to do lifestyle first and fail, or can you go for it from the beginning?
So I think you also have to think about specifically thinking of women as where they are in their life cycle and what their goals are, right? If someone's in their, mid to late 30s and have long established anovulation, you may not have a lot of time. And so actually understanding when you might choose a medical or a surgical option and when you might introduce it earlier, I think depends on what their goals are and the other conditions that are affected specifically in women.
That could be some of our, weight bias that is coming from healthcare providers. You need to prove, right, that you can earn the right to access to a very safe, effective tool. We don't do that with other medications or other diseases, right? This whole idea of you need to do a 3 or 6 month trial and build up more frustration before I'm going to offer you a treatment tool is really the bias that we have on the disease. I agree with you. We need to treat based on their complications and their health.
Yeah, I think it's a tool, and if they, meet criteria for that tool, then it's an option. And I don't think anybody has to prove or disprove that that option, is legitimate for them. I agree with you. I think we've put obesity and weight management in a different bucket than we've put things like diabetes or high blood pressure. I always say I don't make my high blood pressure patients go on the DASH diet or low sodium diet and prove that a low sodium diet won't work. I treat their blood pressure with a pill, and we're getting where we have medications that we can do that with. So it's a really exciting time, I think, as we see more and more and more options, knowing that any one option is not going to work for everybody.
That's the other question I get asked all the time. When do I switch agents? When do I change, right? If we have a statin that doesn't work or has a side effect, we would switch to another. And that's not a process that is new to a provider. And yet with obesity medications, there's a side effect. Oh, that's a bad class of medication. I'm never doing that again. Yeah. Now that we have more and more options, try something else.
And part of it is our history. We kind of have a history. The weight loss medications have had some serious side effects, and so the history is kind of tainting that a little bit. But I agree. I think we need to be better at realizing we need to match medication to the individual, just like we match all treatment to the individual, and we do it really well in other areas. We need to start thinking about it more in weight.
So I think that the shared decision-making with the patient about what their goals are and where they are, and to understand, what are the risks and benefits of the different treatments, and, tailoring it to what's right for the patient at that time continues to be the dialogue that we need to be having with our patients.
Sometimes I add medication because the patient's not willing to go there. So they also are unbiased on their own self, saying oh, that's cheating. So I don't want to take a medication because that's cheating, right? And so how do you address that?
Yeah, I think that's education and explanation and that shared kind of thing also. But one of the other things that I see a lot is the idea that you do need to be on these medications long term. And a lot of patients are still kind of pushing back about that. They understand that you'd have to be on a high blood pressure medicine long term or diabetes medicine potentially long term, and maybe unless you lost some weight, but that you need treatment long term for the chronic conditions. But when it comes to weight, they're like, oh, I'll be on a medication, but I just want to do it until the weight's gone. I just want to be on it for 6 months or whatever, and then I don't want to be on it anymore. I don't want to take it forever. I struggle a little bit with trying to get that message across that this is something that it's like a blood pressure pill, that you do need to take it chronically, that it's going to lose its effect. It's not going to continue. You're not going to continue to maintain a weight loss if you stop taking the medication.
I think that's when the negotiation and the setting of the goals happens again, right? So absolutely, if you want to intensify your lifestyle, I'm 100% here to support you with that, and we can work on different things. But let's set some short-term goals. If we haven't lost 5% in 12 weeks, then I would like to bring up the idea of medication again, because this is a disease, and I would do the same if someone's blood pressure was going up and up and up and the DASH diet was not working. We'd say, it's time to add medication, and treating this with the same chronic disease model.
Yes, totally agree.
I have heard that there's lots of medications out there, and I really want to try one, but which one would be the best one for me and for my body? If I decide to try the medication, which one will work for me and how well?
So more and more medications are becoming FDA approved for weight. We now have this toolbox. We now have multiple options. What's available out there?
It's a really exciting time in the area of anti-obesity medications. We now have 5 FDA-approved medications for obesity. All of them really are with the indication of a BMI of 27 with a comorbidity or a BMI of 30 and above. We've had some medications such as phentermine for 40 plus years, but it has a lot of baggage with it because some people had some side effects with it. Our agents have ranged, the FDA had set a range of 5% total body weight loss as a set point to getting FDA approval. So our first agents that came on the market hit that 5% and then went up to 10. So we have phentermine topiramate, and now we have bupropion naltrexone. And then we now have a GLP receptor agonists, which are initially approved for type 2 diabetes, but we're seeing double-digit numbers in the 15 to 18% average total body weight loss. And some of our newer agents are hitting even over 20% weight loss.
Which is kind of starting to put us in that surgery
Absolutely.
Category.
And we know that while we see tremendous health benefits with as little as 3 to 5% weight loss, in particular with hypertension or some cardiovascular risk, the more weight loss we get, the bigger effect it's having on these complications, in particular when we get into the double digits. So seeing now our newer anti-obesity medications consistently hitting majority of people over 10 to 15% weight loss, we're getting closer to a vertical sleeve, which is, on average 22 to 30% total body weight loss. So this is an exciting time. We also have some devices, which are things that we may consider as medications, but the FDA categorized it as a device that's approved for as low as a BMI of 25. And these are these super absorbent hydrogels that are capsules that people take that has shown to decrease total body weight loss at all. So it's an exciting time that we have these new tools.
Yeah, and I love it that we have a bunch of tools now. It's about kind of matching them to the patient. And if this one doesn't work, we can try this one, and we can start to really play instead of we only had one. Well, or we only had 2 or 3. It really didn't have as many options. Now we really start to have these options. So that's a good thing because we know not everybody responds to every medication. In any of these trials that you look at, you have big losers, people who lose in some of the bigger ones, 20, 25%, and then people who, even on that same trial, lost maybe nothing or a very small amount. So it is about starting to match, but then I guess the downside is how do you do that, right? How do you start to match medications to the person?
I think it's an important point to talk when everybody wants to know, if I take this medication, how much weight am I going to lose? And the trials are really just, as you said, they're just trials, right? So we know that the average person may have lost 14%, but many of our patients lost much, much more, some not as much. So when I am thinking about which medication to put a patient on, sometimes we think about this constraint of like the 5 C's. So obviously we look at contraindications. So there are certain populations that we want to avoid certain medications for us. We'll look at that. We'll look at complications. I try to team up the other obesity-associated complications with medication. For instance, depression. Many of our women, as we discussed, may have a mood disorder. So medication such as bupropion naltrexone that has an antidepressant in it may be a good idea. Or migraines. We use topiramate often in our patients who have chronic migraines. And so phentermine topiramate might be a good mix. So I'm always trying to match. Then I look at cues. Some people will tell me, I'm so hungry at night, right? It's after dinner is when I'm really munchy. So phentermine topiramate may not be a great choice for them because we want to take that one in the morning because of the stimulant effect of phentermine. And then obviously, if somebody also has type 2 diabetes, wow, a GLP receptor agonist would be my first choice. Increased efficacy as well as treating their type 2 diabetes. So looking at cues as well. And as much as I spend all this time looking at it, it really comes down to cost and coverage, unfortunately, so much of the time. Many of these medications can be very expensive. Some are available with just a BMI of 25. So looking at cost and coverage of what a patient can afford really affects what drug I choose.
And the idea that this isn't a medication for short term. We are looking at a long term, if you start this medication and then you stop it, the odds are you will regain the weight. That's what the clinical trials would show. I know a lot of times people say, well, I'm going to make some lifestyle changes, and that's possible. But when we look at the data would say the weight, as long as you're on the weight loss medication, you're going to maintain that weight loss, but stopping it, you tend to regain the weight. And so cost kind of comes in. You're not looking at, I just need to buy this I just need to cover this for 3 months. We're looking at much longer, which I think is part of the problem. How many people could use these drugs? How long do they have to be on them? What is the cost of that? And how do we deal with that in our healthcare system?
Getting a patient to understand that this is, again, a chronic disease, right? If you stop your blood pressure medicine and your blood pressure goes back up, we wouldn't say, oh, see, that was a bad medication. We would say, well, you need to restart the medicine. This is a chronic disease. And so when we are discussing options, we need patients to understand we are thinking about this for a long term. I never want to tell a patient, you're going to have to stay on this for the rest of your life, right? But I do want them to understand that unless we really have intensified our lifestyle program and got these behavioral changes, set, the chances of you gaining the weight back off the medication are high.
Yeah, because regaining that weight, that yo-yo is a big deal, right? It doesn't feel good. That's not what you want to be setting your patient up to do. And so I do think it's an important conversation to have.
Without maintaining the weight loss, you're going to, be predisposed to some of the other conditions that you hopefully have helped ameliorate by the weight loss. So specifically thinking about women, women will be more likely to be able to conceive. So without maintaining that weight, they won't be able to do that. You will have decreased, the risk of menstrual irregularities, potentially, affected long-term, cancer risk in this patient population. So understanding that this is sort of part of the lifestyle change, I think is a critical component.
We know for some conditions with women that they need more weight loss than just that 3% on average with lifestyle. And so things like urinary incontinence or PCOS that may need at least 5 to 10% weight loss to have true meaningful effect may be a reason to start medication.
I think it's important to think about, in the risk and benefits of starting a medication, specifically with women, is you need to think about the benefits. So, we've talked a little bit about menstrual irregularities and contraception, but just maintaining a person or taking care of a person in pregnancy at different BMIs, there are different risks that are associated, and those risks are elevated by each stage, for example, of obesity. So, for example, your risk of stillbirth, your risk of a section and labor, all of those increase with each level of obesity. You go from basically up to a 3-fold increase, for example, if you have stage 3 obesity. So even if you can move from stage to stage, it creates actually a safer pregnancy for the patient.
We're planning to expand our family in the near future. What medications would be safe for me to take?
It's important for us to discuss that all of these anti-obesity medications are contraindicated during pregnancy. So when would you stop some of these medications before conception?
Yeah, so I think it's really important that when you are prescribing obesity medications, that you make sure that the contraception for that patient is managed. We would usually stop most of these medicines at least 2 months. As a general rule, it would be 10 half-lives. The FDA has certain recommendations and requirements for each of these medications, so it's important to familiarize yourself with those. But as a general rule, at least 2 months. And we've already talked a little bit about bariatric surgery. But there are changes with bariatric surgery that result in nutritional deficiencies, and we really want to have a long startup period for that of a couple of maybe 1 to 2 years before you would contemplate a pregnancy.
So what if someone does get pregnant? They're on the drug. What do you do? What's the plan at that point?
So especially with some of these newer drugs, we would try to enroll those patients in a registry so we can learn about them, but we would follow them differently as far as growth during the pregnancy. And so there would be, frequent ultrasounds. You have to realize that the background risk for women to have fetal anomalies just because of an obesity diagnosis is far greater. So you have to understand that there is a background risk that is not the same background risk as in a normal non-obese patient. And so you have to take that into consideration when you think about that. But that's why we still have so much more to learn in taking care of these patients.
It's all about that risk-benefit ratio, right? Just because there's a risk on the medication, the benefit of them losing the weight before pregnancy is so significant.
And there's a risk for not losing weight, right? And we never think about that risk, right? Not losing weight. There's a risk associated with it, and that has to go into it too. So it's a complex
thing. And yet that's
thing.
not associated with a healthcare provider's prescription. And so I think that could be where some of the hesitancy in prescribing some of the newer agents to women of conception years.
So even in the last year or 2 years, there's been a complete change in the way we do surveillance for pregnant patients that have obesity. And so we are now, because of the increased risk of stillbirth, we're recommending induction for the patients, and we're also doing antenatal fetal surveillance for patients. And so increased risk of miscarriage, increased risk of stillbirth, increased risk of fetal anomalies, all of those things are standard background risk in the overweight and obese population over a normal weight population. So again, taking all of those things into consideration. And that's just pregnancy. That doesn't involve, as you mentioned, women that suffer from incontinence and pelvic floor disorders. They are going to be oftentimes, if not cured, greatly improved from their underlying disease just because of the weight management.
So what about if the medications aren't working? What if sometimes when we have extreme obesity, body mass index, that are up in the 40s or 50s or even less than that, but have a lot of comorbidities, have a lot of other health conditions that are associated with the weight? Are there what other options do you think about?
Well, there's bariatric surgery. And, I think same with the baggage of pharmacotherapy, bariatric surgery has some history. Many of us in primary care do not have a lot of education or training in the type of bariatric surgery procedures that are available. And the data showing the mortality or morbidity, even remission with diabetes, is very strong with bariatric surgery. So I think that is something that with more education and explaining how it works. It's not just a matter of shrinking your stomach and making people feel hungry for the rest of their life, but it's a metabolic as well as a physical change.
And we've seen the same thing in obstetrics and gynecology, taking care of women through pregnancy and watching women that previously were infertile conceive and they were anovulatory, and learning how to take care of women and learning the signs and symptoms and complications of bariatric surgery often mimic some of the normal signs and symptoms of pregnancy. So raising, the alertness that you must have when you're taking care of patients who have bariatric surgery is important.
So I guess the most aggressive tool that we have in the toolbox are bariatric procedures or bariatric surgery. And I think there's some new guidelines out there for when we could consider that in our patient.
There is. First of all, I want to tell you that the data on the safety and efficacy of bariatric surgery is amounting. And so in particular on diabetes regression and remission, even some people would say diabetes cure, as well as increased mortality and disability associated life years, so meaning living longer without disability, is very strong with bariatric surgery. The indications have changed, so we've lowered the bar. And so it's a BMI of 30 with comorbidities or a BMI of 35 without. Yeah. There's two major bariatric surgery procedures that are done. The one is the vertical sleeve. So the vertical sleeve is restrictive by reducing the size of the stomach. And it does, because reducing the size of the stomach, also metabolic. It decreases ghrelin, which is the hunger hormone, right? That gremlin in our stomach that makes us hungry. And then the Roux-en-Y gastric bypass. That has the most effective in terms of the amount of weight loss. And that is also restrictive and metabolic. It's just a little bit stronger. On typically we would say vertical sleeve expects somewhere between 20 to 25 or 20 to 30% total body weight loss, and then Roux-en-Y gastric bypass 30 and more. So a very effective
Getting more of a
therapy.
malabsorptive type thing with the bypass.
With the bypass.
Versus the sleeve, and therefore getting a little bit greater.
Right, we really
potential
think
for weight
it's
loss.
increasing GLP-1 and having more of a metabolic effect as well.
You know, I think it is interesting that we've decreased the BMI cutoff for when you can consider doing a bariatric procedure, doing a surgery. And I think what that shows is just what you said at the beginning, that it's safer. We're willing to take the risk because the risk isn't as great as we thought with the surgery, so we're willing to do it at a lower BMI. Before, we used to have that BMI set higher because we felt like it was more risk, and you needed to be at a higher risk before we were willing to take a risk for surgery. But actually, by lowering it, I think two things. It's not quite as risky. We realize the outcomes, you know, we've gotten better at it, is kind of what you're saying. And we have more and more data that it really can do things, like you said, with that type 2 diabetes, that there's a lot of good benefit that can come out of these procedures. So, you know, I think considering them, having them in the toolbox, working with a good surgeon, knowing where to refer people, making sure you understand the complications in post-surgical care, what you need to be testing for in terms of any type of malnutrition, if it's a gastric, bypass, et cetera. And then I think when it gets into women, there's even some special things that we have to kind of think about too.
Yeah, I also think one of the reasons that the procedures have become safer also has to do with the fact that there are centers that include all of the services that you would need to take care of a patient actually having a gastric bypass or a gastric sleeve. And so people are doing procedures that they do every day, and they do them repetitively, and so the more you do something, the more skilled that you get at it. And so it's been really, I would say, a great development across the country for patients that are in need of these procedures.
Do we see regain after surgery, or does the surgery just take care of everything?
Oh, I think that's a really good point, because many patients will think, oh, well, surgery is just a simple answer, right? I'm just going to have the surgery and everything. It's a chronic disease. So that lifestyle part is important. And while a lot of the surgical effects are due to metabolic changes, meaning changing hormones in our body, some people may require medication for weight maintenance after their big weight loss phase. That follow-up, and I think that's why the success has improved, is because there is more follow-up after bariatric surgery. It's not a one and done.
Yes, and I think that's really important. You still may use some other tools in your toolbox. Just because I've had surgery doesn't mean that you can't add a medication, or that doesn't mean that lifestyle isn't still part of the picture. I like to think about surgery when my patient, and I say this to them, the surgical tool is sharpest at the beginning, and just like any tool, it gets duller over time, meaning its biggest effect and where you have the most potential for weight loss is at the beginning. Take advantage of that. Get as much weight off safely as we can, but recognize at some point we may need to add some other stuff because it will start to lose its impact. And so I think that's an important way for healthcare providers to think about it, and not to think, oh, it's just a solution and then we never have to revisit the chronic condition.
I think follow-up is a really important point, and we've kind of talked about that as we've worked our way through some of these modules. We wouldn't take care of any other chronic disease as sort of a one and done, right? We would require follow-up, intervention, tweaking, individualization, and I don't think that's any different here.
Yeah.
As a non-surgical person, I'm the first to say, then I want to see you back, right? When you plateau, or if you start seeing weight come up, that's when I can have the most good. So don't wait.
Yeah. And I always, like I said, if you're going to take the risk with a weight loss surgery, and there is a risk, right? There's a potential benefit, but there is a risk. Any surgical procedure, you're going to take that risk, get the biggest bang for your buck out of it. So I'm going to help them try to maximize safely what they get out of it, and recognize that, don't reintroduce calorie liquids, high sugar liquids, try to stay away from that. Let's try to use and get the biggest benefit, because there is some risk. Let's counterbalance that, and really explaining that to the patient. Once again, having that relationship with them.
And the exciting news is that some of our pharmacotherapy is reaching those same numbers. And so it's this layered approach of combining things, I think, is the future.
Yeah, and I think that's good for the healthcare field. We typically don't like to treat things that we don't think we can impact. Imagine that. And now I think we are at a place where we can have an impact, and we really, our skills and understanding, using all the medical side of things that we know and what we're good at, we can actually help people lose weight and keep it off now. And so it doesn't feel as heavy as it used to be, like, I don't really have anything. It's really hard. I think now we're turning the corner and we're getting where we are really going to be able to make some impact.
Absolutely.
I do get a lot of questions from my patients about, well, if I have the bariatric surgery, how does that affect, me potentially getting pregnant and the pregnancy itself? What do you usually talk about that?
So the pregnancy itself, conception's actually improved, specifically in women with PCOS and that suffer from obesity. But we see conception and natural conceptions much more rapidly after bariatric surgery. Now, we recommend, because of the changes in bariatric surgery, that patients wait for at least a year to 18 months before trying to conceive. And we've seen even the Canadian data recently is coming out with a recommendation to wait on pregnancy for almost 2 years. And the reason is to allow some of the nutritional imbalances to correct, et cetera, prior to pregnancy, because we see really small for gestational age babies when pregnancy occurs too early. We continue to take care of patients when we see that happen. We monitor them differently and we care for them differently. Taking care of a patient in pregnancy that's had bariatric surgery really requires a different level of surveillance, making sure that the nutritional deficiencies are addressed, and watching that patient for fetal growth throughout the pregnancy. The other sort of benefits of pregnancy after bariatric surgery is we see decreases in gestational diabetes, decreases in the hypertensive disorders. So there's some really positive benefits, and although rare, after bariatric surgery, we have to be very concerned about bowel obstructions and volvulus and other bowel conditions, especially depending on the type of bariatric surgery that a patient's had. And so that awareness that a provider must have if they're taking care of a patient that's had previous bariatric surgery is really important.
Having this data is just so powerful. Bariatric surgery is obviously not for everyone, but to hear that OB-GYNs are having the training to have safe and successful pregnancies is really powerful.
Another really important consideration for bariatric surgery is how you manage contraception until the patient is ready to conceive, or if they're not ever ready to conceive, how you manage that. So traditional oral contraceptives, either progestin only or estrogen-progestin combination birth control pills that people commonly use, are really not a good idea due to malabsorption. So really long-acting reversible contraception, either in the form of implants or in the form of an IUD, is really what I would consider the gold standard for how you manage contraception in a patient that's had prior bariatric surgery.
When we bring up the issue of contraception with our patients with obesity, many will say, oh, don't worry, I've never had a problem. And so when they're successful with their weight loss plan, it's really important to educate them, well, now you could have increased fertility.
Yeah. See that all the time, right?
Yes.
Definitely. Kind of unplanned, didn't think it could happen, and it happened. So I think it's great to bring that up, make them aware.
And because that period is really long, right? A year to 18 months after bariatric surgery, that's the time that needs to sort of be protected. So having that as an a priori discussion with your patients is critical.